Welcome. This is going to be the lecture on Chapter 11, Anger, Hostility, and Aggression. So some key points. Anger is a completely normal, strong emotion. It's a response to real or perceived um, stimuli, provocation. So frustration, feeling hurt, just feeling fear. It can be positive force when expressed assertively. It kind of energizes our body. Think back to med surge and your flight or fight response with your nervous system. However, we can also have any inappropriate expression or sometimes suppression, which can cause us to have physical, emotional, or relationship issues. This chapter is going to talk about some hostility, some physical aggressions, how we're going to handle our psychiatric settings, and overall the nurse's role in recognizing and managing hostile and aggressive behaviors in the psychiatric client. These are the key chapters or the key terms that your chapter highlights. These are the learning objectives that the chapter highlights. So again, anger. Anger is a normal emotion. It's often perceived negatively, but can be healthy reaction to unfair situation, unmet expectations, or disrespect of our personal rights. Can lead to problem solving and conflict resolution if it's expressed assertively. Negative consequences of anger or denial and suppression. Holding in anger can lead to physical issues like migraines, ulcers, coronary artery disease, and emotional problems like depression and low self-esteem. We do have inappropriate expression, which can escalate to hostility and aggression. The nurse's role in anger expression, nurses can model appropriate anger expression, teach assertive communication, which would be techniques such as I statements. I feel angry when, and then they say when the person does the action that causes them to have anger. Assertive communication helps in expressing anger constructively and fosters production of discussion. We also have catharsis. Catharsis is an activity like hitting or punching a bag or yelling. This helps to release anger. However, there are some studies that show that it actually can increase anger because if your human response is to hit a bag every time you're angry, if you get angry and you don't have a bag, there is a potential that you could hit somebody. So depending on what literature you're reading would be if that level of catharsis is good or bad. It can also help with non-aggressive activities like walking, talking. So some people say when they get really mad, they go for a run, and that's their cathartic release of their anger. Some cognitive behavioral techniques. We can do some distraction, some problem solving, some reframing. All of that can help them manage anger during provoking situations. Health risks associated with anger. High hostility and anger are linked to coronary artery disease and hypertension. Suppressing the anger can worsen these conditions, while healthy anger management techniques, such as that assertive communication and mindfulness, are really beneficial at reducing these health risks. Anger suppression in women. Women are often socialized to suppress anger and to maintain relationships. This leads to a lot of somatic complaints and psychological issues. Women's anger typically arises from being denied power, resources, or respect, especially from close, intimate relationships. Women need to recognize the importance of acknowledging and expressing anger for personal growth and development. Hostility and aggression. So hostility and aggression is the behavior that can develop. It's more sudden and it's unexpected, and it's often followed with these different phases. So the phases of the aggressive behavior, usually we have our triggering phase, and this is going to be an incident or a situation that kind of provokes an aggressive response. Then we have the escalation phase, which the behavior starts to intensify. The crisis phase is when they lose the ability to perceive events accurately. They're no longer able to problem solve. They're having difficulty expressing any feelings. They really don't have control. And that's typically when physical aggression is going to occur. Our recovery phase is the gradual reduction of aggression. And then there's post-crisis phase, and this is the aftermath of the aggression. And it's usually characterized by maybe a calmness or remorse in the client. It's really important that we identify that triggering phase and implement intervention at that point. Putting interventions in during the triggering phase, and even the when they're having escalation, those phases, if we hit it then, we can usually prevent off that physical outburst and manage their behavior more effectively. So the onset and clinical course of anger, again, it's always perceived as negative. It's not healthy to deny somebody or to try to eliminate that, but we want to help them reframe, restructure, and have more of a cathartic response to release their anger than that inappropriate expression of hostility and aggression. Again, catharsis, cognitive behavioral therapies, like when you start to feel this way, let's do some mindfulness, let's do some running, let's do some journaling, get those feelings out, but in a more socially appropriate way. And then the suppression, especially in women, we know is very common. The onset, okay, so this is just a little bit further into those phases. So triggering an event or circumstance in the environment which initiates the client's response. This response is typically anger or hostile. You are going to see the client slowly starting to build up during the triggering phase. They're going to start to get really restless. They're going to be anxious. They might be a little bit irritable. They might start pacing. You might notice some muscle tension, some rapid breathing, louder voice. They're starting to get angry. This is when we as nurses need to intervene. In the emergency room, I would often see clients in this triggering phase. They're waiting for their test results. They've been here for hours. They're starting to get stressed, and you can see them slowly cycling up. When we hit that escalation, the client's response represents that escalating behavior. It indicates movements towards they're going to have a loss of control. Their flight or fight response is turning into fight. They're going to have a flushed red face, or they might be pale. They're going to be yelling. They're going to be swearing. They're going to be agitated. They're going to be threatening, demanding. You might see clenched fists, threatening gestures, verbal hostility, and they're starting to lose the ability to think clearly or problem solve in total. When we have that crisis during an emotional or physical crisis, so the client has lost control, they do not have the ability to think clearly, they're running completely off of that like amygdala response of no emotional control, no physical control. This is where they're going to be throwing objects, kicking, hitting, spitting, biting, scratching, screaming. They're not going to be communicating clearly. As the client's behavior escalates towards crisis phase, again, they lose the ability to perceive events accurately. They're not going to be able to solve problems. They're not going to be able to express their feelings appropriately. It's just going to be physical aggression and anger. So again, why we need to stop during that triggering phase, during that escalation phase, is because when we get to this phase, we have somebody in that true fight response. After all the release, we get the recovery, the client starts to regain physical and emotional control. They're going to start to lower their voice. You're going to see their muscle tension fading away. They're going to be more clear. They're going to be more rational, and they're going to be more physically relaxed. The post-crisis, the client's going to attempt to reconcile with others what they've done. We're going to have remorse. We're going to have apologies. We might have crying, quietness, withdrawal from behavior. So then we have some related disorders. So things that, the DSM-5 kind of relates anger to. So people with various psychiatric disorders can show anger, hostility, and aggression. If you have somebody who has paranoid delusions, believing that others are out to get them, leading to this high aggression levels. Auditory hallucinations, hearing voices that command them to hurt others. Dementia, delirium, head injuries, and intoxication can all lead to aggressive behaviors. And then our personality disorders, people with antisocial, borderline personality disorders, even our paranoid personality disorders, these all have higher levels of aggression. We can have depression and anger attacks. Some clients with depression experience anger attacks. These are intense spells of anger and emotionally trapping situations, typically resulting in verbal outbursts. But these guys usually do not have physical aggression, and they are followed by remorse. Hitting back up to the topic that I just talked about with the personality disorders, remember that antisocial personality, they're not going to have remorse for their actions. We have intermittent explosive disorder. This is a rare disorder marked by disproportionate aggressive outbursts, often resulting in serious assault or property damage. This person feels tension before the outburst and relief afterwards. They do have some remorse between their episodes. Intermittent explosive disorder usually develops in late adolescence to about the third decade of life, and it's commonly seen in frustration, often in male individuals. And when we get to our week 12 lecture, we go more into our disruptive behaviors. So we'll talk about that more at that point. Clients that act out and use this as an immature defense mechanism, where individuals express emotional conflict through actions rather than reflecting on feelings. Acting out is more common in children and adolescents who struggle with those intense emotions and conflicts. And then we have violence and mental illness. So reports of violence is often linked unresolved anger or mental illness to violent acts. However, these reports may stem from personal perceptions or speculations and are not every violent act. So yeah, that's saying that not every violent act is linked to a mental health disorder. So some etiologies, we have the neurobiologic theories that talk about our neurotransmitters. Research have explored how neurotransmitters affect our aggression, finding that low serotonin levels is linked to increased aggression. Increased dopamine and norepinephrine can activate impulsiveness, which is linked to our violent behaviors. We know that brain damage can cause this. Specifically, if you have frontal lobe damage, your frontal lobe kind of stops your amygdala from having those emotional responses. But your limbic system and your temporal lobes, as well as the frontal, if they're impaired, we can have those aggressive regulations and leading to those aggressive behaviors. When we look at our psychosocial theories, development in childhood, infants and toddlers express themselves intensely with temper tantrums being common as their needs are unmet. So if we have needs that are continued to not be met, then we have these issues that develop. As the child matures, they should be developing impulse control and socially appropriate behaviors. If they do not, then we're going to have these issues. Positive relationships and success in school foster that emotional development and self-regulation. Noting that we do have sometimes dysfunctional families. Dysfunctional families, children in these homes with poor parenting or social challenges are at a greater risk of failing to develop proper behaviors, leading to impulsive and aggressive behaviors. And if that becomes their norm, then that's how we kind of have like that family history of violence. Because if dad always beat mom and that seemed to be normal, then it's going to be normal for them to beat their spouse and so on and so forth. We also have interpersonal rejection. So rejection can trigger anger and aggression, especially if it causes us emotional pain, frustration, or threatens our self-esteem. Aggressive behavior may be used to regain control or improve mood, but it does not often achieve the intended result. Cultural consideration, as always, culture really needs to be examined. Culture influences on anger, plays a significant role in how anger is expressed. As a nurse, you should be aware of cultural norms to provide effective culturally competent care. In the United States, women were historically discouraged from expressing anger openly, as it was considered unfeminine and challenged male authority. This norm has slowly changed. Some cultures view expressing anger as rude, disrespectful, and they may avoid it entirely. Encouraging a client to express anger verbally to an authority figure in such cultures might be completely unacceptable. When we talk about our healthcare disparities, historically, mental health disparities in screening, diagnosis, and treatment were attributed to racial and ethnic differences. Today, social detriments of health are recognized as the main cause of these disparities, influencing health outcomes at multiple levels. Reducing mental health disparities and promoting equality requires community engagement, improved community-based healthcare services, and addressing social detriments of health broadly. We do have some cultural balance syndromes. The first one, Hawabuga, I can't say it. This is from Korea. It's a cultural syndrome attributed to suppressed anger, often seen in women. Symptoms include sighing, abdominal pain, insomnia, irritability, anxiety, and depression. Traditionally misdiagnosed as depression or somatization disorder. The next one is from West Africa and Haiti. This is characterized by sudden outbursts of agitation, aggression, confusion, and psychomotor excitement, often accompanied by hallucinations and paranoid ideations, resembling a brief psychotic episode. And then that last one, amok, is seen in Southeast Asia, Caribbean, and with Navajo. It's a dissociative episode marked by brooding, followed by violent aggression or homicidal outbursts directed at people and objects, triggered by perceived insults, typically seen in men. The behavior is found in, Malaysia, Puerto Rico, and among the Navajo, as I said at the beginning. So these are just questions I have built in. Hostility and aggression are terms that can be used interchangeably, and we know that this is false. Hostility and aggression are two different terms. Hostility means verbal aggression. Physical aggression involves the act of injuring another person or destruction of property. So hostility is verbal and aggression is the actual action. Treatment. So treatment of our aggressive client typically focuses on addressing the underlying or comorbid psychiatric disorder. So are we aggressive because we're schizophrenic? Are we aggressive because we're bipolar? Are we aggressive because we have antisocial personality? Successful treatment of that underlying disorder often leads to better management of the aggressive behaviors. So we definitely want to do psychotherapies with these clients. We can use some medications for aggressiveness. So lithium we know is great at our bipolar disorders, right? It's a mood stabilizer. Can be used in conduct disorder, and sometimes we use it for intellectual development disorders. Then we have carbazepine, which is Tegretol, or valproate, which is Depakote. These are also our mood stabilizers. We can use them for aggression linked to dementia, psychosis, and sometimes with our personality disorders. Our atypical antipsychotics like risperidone and olanzapine. These are effective for aggression with dementia, brain injuries, intellectual developmental disorders, personality disorders. I see a lot of risperidone with our autistic kiddos who have some impulse aggressive issues. Benzos can be used. They do calm the client down with our irritable and agitation in our older adults. However, sometimes it leads to worsening aggression. And of course, anytime we do a benzodiazepine, we have risk for falls and respiratory complications. Sometimes we can use Haldol in our older adults to help reduce agitation. Haldol is also good for delirium. But remember, whenever we're using any of the antipsychotics, we have to go back to our extrapyramidal side effects, those EPS. And remember, we treat those with benztropine and cogentin. Sometimes we can just do seclusions, where we put the patient in a low stimuli environment. That can help to reduce that crisis phase. But remember, there's legal and ethical considerations when we're doing any type of seclusion or restraint. Now we're going to go into the nursing process of this. So first off, we need to start with our assessment, right? Nursing process is our ADPI. So the nursing process of assessment, we want to figure out and assess factors influencing the aggression. So is the behavior less common in the unit with strong leadership, clear staffs, planned activities? What's our predictability? Are we going to see it when we have the client in meetings and groups, when they're interacting with other people? Is that what leading to their frustration? Or is it when they're in a space where there's not as much activity and then that's triggering their aggression? So kind of like what is leading to these aggressive factors? We can do individual client assessments. So do we have a history of violent and aggressive behavior? Is one of the, if they have a history of violence or aggressive, that is the best predictor for future aggression. Understanding how the client handles anger and what they believe is helpful for managing their anger is always key. Clients who feel unheard and frustrated are more likely to display hostility and aggression. History of victimization or substance use also increases the likelihood of aggressive behavior. Individual clues to watch for would be beliefs that hallucinated voices are powerful, or if they are saying that people around them are evil, or if they can't ignore them. Changes in speech is also something that we want to look for. If we start to see that their volume's going up, that their speed is changing, looking at their facial expressions, are they starting to get red in the face? Are they starting to get pale in the face? What's their muscles look like? Are they getting tense? What's their behavior like? Are they starting to get restless? Are they starting to pace? So again, when we think about those phases of the aggression cycle, triggering, when the patient's getting triggered, they're going to have that louder voice. They're going to start to have rapid breathing. They're going to have changes to their muscle tone. They're going to start to have some restlessness, some anxiety, some irritability, some pacing. When they get to escalation, their face is going to be flushed or pale. They're going to be yelling at this point. They might be swearing. They're going to be threatening. They're going to be demanding. They're going to be clenching their fists. When they hit crisis, there is loss of emotional and physical control. We're going to be throwing objects, kicking, hitting, spitting, biting, scratching, screeching, screaming, and they're not going to be communicating. Crisis is like that toddler on the floor who just has no control. Recovery, we're going to have lowered voice. Their muscle tension is going to start to go back to normal. They're going to be able to communicate a little bit more clear, and they're start to kind of have physical relaxation. Post-crisis is going to be remorse. We're going to be apologizing, crying, quiet, withdrawn behavior. Your safety approach for this, you always want to make sure the assessment is done from a safe distance to avoid making the client feel trapped or threatened. It may be wise to have 2 staff members to approach the client to ensure safety and effective teamwork. So your data analysis and priorities. Always number one concern is safety, safety, safety. This client has a risk for violence. This client is having ineffective coping. If the client is intoxicated, depressed, or psychotic, additional problems may be identified. Your outcome identification, right? We're going to want the client to not harm themselves, not harm anybody else, refrain from those intimidating or frightening behaviors. They should be able to describe their feelings and concerns without having aggression. And overall, the client will comply with treatments. So what's your nursing actions? All right, if we have a hostile and verbally aggressive behavior, even for an experienced nurse, this could be intimidating. So in those social settings, it's very common response to avoid the hostile individual. But in the psychiatric setting, engaging the hostile person in a dialogue is often the most effective way to prevent escalation to that physical aggression. Some effective actions, early intervention in the aggressive cycle leads to more effective and less restrictive outcomes. So what that means is that if I have a client who I start to see is triggering, ignoring them is not going to fix or stop that trigger. So having an active dialogue, you know, you seem to be in some type of distress. Is there something I can do to help you with this? Do you want to talk about something? You know, recognizing the fact that they appear to be going through something and trying to help them work that out, are all effective early interventions in that aggression cycle. Managing the environment, we can do group and planned activities like playing cards, watching or discussing movies, or having informal discussions gives the chance for the client to express themselves, and help calm and reduce boredom, because boredom can sometimes create some agitation, anger, and lead to these aggressive outbursts. One-on-one interactions, scheduled individual interactions demonstrate the nurse has genuine interest and willingness to listen to the client and can help offer security to the client. We can do conflict resolution. When the clients have conflicts, the nurse can facilitate problem solving and conflict resolution, allowing the client to express the anger appropriately and practice assertive communication. So again, that would be when you leave me here without telling me my test results, I feel anxious and angry. I would prefer you update me, right? That would be those using I statements. Dealing with psychotic, hyperactive, or intoxicated clients, we always want to make sure that we're ensuring the safety and security of the client, as well as protecting all of those clients and people around them for their potentially intrusive or threatening behavior. Talking with the client about their feelings and providing close supervision for these is really important, because if they have the potential to become very aggressive, and we want to make sure that we maintain a safe environment for them. So managing aggressive behavior during that triggering phase. So this is just that trigger time, which would be like the first part of that cycle. So approach. The nurse should approach the client in a calm, non-threatening manner to use those de-escalation techniques. We want to use empathy, express empathy for the client's anger and frustration. We want to encourage expression, encourage the client to express their anger feelings verbally and remind them that they are in control. Clear communication, very clear, simple, short statements. And you need to allow time for the client to express themselves. Do not want to rush them. We want to use a quiet space. So we want to move them to a quiet area to help reduce any stimulation. But remember, a quiet area does not equal a secluded area that you yourself would then be at risk in. Medications, we want to offer PRN medications if they're ordered as they're needed. We can do relaxation techniques, so mindfulness, yoga, things like that. and of course, physical activities. So, you know, sometimes walking can help relax the client and help them calm down. One of the techniques that I was taught when I was in the emergency room was hearing and communicating with heart. So you would have to hear the patient out. You would have to try to make a empathetic connection with them. You would always apologize. And it was more of an apology that our actions have caused this distress on you, not an admission of guilt that you were in the wrong. And then we would, you know, tell them what our reconciliation for this issue is going to be. And then we would thank them for bringing it to our attention. And that really worked well. And if you want to Google that, listening with heart, there's a lot of free resources about that little program. So a client with a history of violent or aggressive behavior is more likely to exhibit similar behavior in the future. And right, that's true. That was one of the things that we said. One of the most predictable outcomes is if they have a history for violent or aggressive behavior. So when we're managing, if we didn't catch it in the triggering phase, now we're in the escalation phase. So when we're in the escalation phase, we need to take control. The nurse needs to take control of the situation as the client builds towards losing control. We want to use calm, firm directions. Provide clear and firm directions in the calm voice. Put them in a timeout. Direct the client to take a timeout in a quiet area of the room to cool off. We want to make sure that we're setting clear boundaries. Inform the client that the aggressive behavior is not acceptable and that the nurse is there to help them regain control. And we can again offer medication. If the client refuses to take the medication during the triggering phase, we want to make sure that we offer it again to them at this point. So I have a little example here. If we have a client in the day room and they're getting upset and they're throwing a chair, what do you want to do? Right? And what I'm looking for here is that to implement some of these things, right? We want to get them to a quiet area. We want to have extra people with us, right? Because we said before, you know, like this doesn't necessarily need to be a one-on-one because then you're at a higher risk and your safety is important. We want to actively listen to them. We want to calm them in that non-threatening behavior. We need to let them know if they're doing unacceptable behaviors that it is not acceptable. You never want to restrain them right away. And you always want to make sure that you de-escalate them to the best that you can. Remember, restraints, whether they're physical or seclusion, require a physician order, and that is never your first choice item. So the nursing process, when we're talking, like we've now made it past the triggering phase, we've made it past the escalating phase, and now we're in the crisis phase. And the crisis phase is when they are physically aggressive. You know, this is that hitting, kicking, biting, out of control. So what you, the nurse, need to do, you need to take charge for safety. Staff must take charge of the situation to ensure the safety of the client, the other clients, as well as the staff. Staff should have training, and only trained staff should be involved in managing the situation, particularly when we're talking about restraining or seclusions. A lot of hospitals might do a hold where they physically will hold the client, and you really need special education for your body mechanics and for their body mechanics because we don't need anybody getting hurt. You want to follow whatever protocols your system has in place. So the decision to restrain or seclude really needs to align with the facility protocols and standards. Always obtain those physician orders. The nurse should quickly obtain a physician order if we're deciding to implement restraints or seclusion. The restraint procedure, usually you're going to want 4 to 6 trained staff members to effectively restrain somebody for their safety and for your safety. Staff usually have a position within it, whether you're somebody who gets a limb, protects the head, controls the torso. Staff should know what their role is, and the client should be moved to a seclusion room, and then the restraints are applied if necessary. Medication, if not already administered during the jury phase or the escalation phase, this is usually when they're going to get the medication. And it's going to typically be an IM medication in these emergency situations. And at that point, you need to make sure that you're doing close assessment and documentation. You might have to be one-on-one with that client. And then after they get to where they're safer by themselves, if they're still in restraints, there's still going to be a one-on-one. The recovery phase. So when we're in our recovery phase, remember that the client's regaining control. So your role, you want to encourage discussion. Encourage the client to talk about the situation, have them maybe identify what triggers led to this aggressive behavior. Because if we can now identify the triggers that maybe we didn't realize before, now we have new triggers to avoid. We want to help the client relax, assist the client to a relaxing, perhaps by allowing them to sleep or calm down. If you've medicated them, most likely they're going to want to sleep. We want to explore alternatives, help the client explore ways to avoid future aggressive episodes by asking them what they could have done differently. What could have, stopped this at the triggering phase? What could we have done differently to stop it at the escalation phase? We want to make sure that we do a staff member assessment, right? The nurse should always assess any staff members, do a quick debriefing. Are there any injuries? What reports do we need to fill out? What flow sheets? Overall, how the staff felt the situation was handled, what worked well, what needed to be improved, and how the situation could have been diffused more effectively. So all of that should be included in the staff debriefing session. Some client discussions. Again, we want to encourage the client to express their feelings about the incident, but avoid discussing the aggressive client in detail with others. Post-crisis phase. So this is when we're getting sadness, remorse. At this point, the patient should no longer be in restraints or seclusions. They should be removed from them because if they're in this part of the phase, they really should be meeting the behavioral criteria to be removed from restraints and seclusions. Avoid lecturing or chastising the client. Overall, we should never really lecture or chastise our clients. Positive feedback, give feedback for, like, I'm glad you've regained control. Set expectations that, in future events, we really need to try to manage this more in a non-aggressive manner. And reintegrate the client into the milieu, right? The client should be brought back into the activities as soon as they're able to participate. And then our final, right, so those were all of our interventions, and now we're hitting our evaluation phase of our ADPI, our nursing process. So the evaluation care is most effective when the client's anger can be diffused in those early stages. But restraints or seclusions is sometimes necessary to handle our physically aggressive behaviors. The goal is to teach anger, hostile, and potentially aggressive clients to express their feelings verbally and safely without threats or harms to others. So in your evaluation is going to be dependent on all of those interventions that you did. Question: during which phase does the staff debriefing occur? Is it the escalation phase, the crisis phase, the recovery phase, or the post-crisis phase? And staffing debriefing typically occurs during the recovery phase. During the recovery phase, we're allowed to have discussion of the event, how it was handled, what worked well, what needed improvement, and how the situation could have been diffused more effectively. Now we're going to talk about some workplace hostility. So sentinel events you have to alert JACO during sentinel events. Your book talks about in 2008, the Joint Commission issued sentinel event alert regarding intimidating or disruptive behavior. Prior to 2008, that wasn't in the Sentinel categories. These behaviors can lead to errors, decreased patient satisfaction, preventable outcomes, increased costs, and loss of qualified staff members. And we've seen a lot recently in the news about nurses getting hurt. And historically, healthcare settings have kind of said, it's okay. Like nurses can be hit, healthcare workers can be abused. And that's kind of starting to shift. Providers in position of power typically demonstrate behaviors, including reluctant to respond to inquiries, intimidating others, and tone in the inpatient workplace. So, like that is considered workplace violence if your provider is acting like that. Kind of falls into workplace bullying, which came about in 2016. JACO kind of expanded its focus from just client based to workplace based. And this would be characterized by abusive conduct such as verbal abuse, threats, intimidation, humiliation, and sabotage. In 2022, JACO started required accreditation healthcare organizations to implement specific standards, such as code of conduct policies, which defines acceptable and unacceptable behaviors. All institutions should have a process for managing disruptive behaviors that should be led by management. Education for all team members, unexpected professional behaviors, and a zero tolerance for unaccepted behaviors, ensuring that everyone is held accountable. And again, all of that is really focusing more on staff to staff violence. Patient to staff violence still is long ways away from being acceptable. And overall, right, these steps help to improve workplace culture, promote safety, and enhance our team collaboration. Community-based care. So this talks about management of comorbid psychiatric disorders. For many clients exhibiting aggressive behavior, managing the underlying psychiatric disorder is really key to controlling the overall aggression. We have some anger management programs that help provide a setting for clients to express their emotions, learn problem solving, practice conflict resolution techniques. We have some community-based assaults, which are clients that are discharged from the hospital inpatient or acute care setting, and they have an increase in assaults by clients in the community settings. Contributing factors include stressful living conditions, increased access to alcohol and drugs, availability of weapons, and non-compliant with medications. These incidents are often triggered by denial of services, acute psychosis, or excessive stimulation. There are some research being done on assaults that show that assaulting community residents are found that clients who are most likely to be assaulted were older males or schizophrenics or younger clients with budding personality disorders. The Assault Staff Action Program is a response to this. It was established in Massachusetts to support staff victims in community-based residential programs. The program helps staff cope with the psychological aftermath of assaults, evaluates better ways to manage aggressive clients, and works to enhance safety in these settings. Community-based care approach aims to improve the safety and well-being of both the client and the staff, trying to identify root causes of aggression in a supportive and structured manner. And then this is the last slide. So this talks about our self-awareness issues. Nurses' role in managing anger, self-awareness. Nurse must be aware of how they personally respond to anger. If the nurse feels uncomfortable with or avoids a client in anger, it can allow the situation to escalate. On the flip side of that, if the nurse reacts with anger, the situation can turn into a power struggle, and reducing the chances of de-escalation of the client's anger. So it's really essential for a nurse to remain calm and self-aware in order to manage the situation effectively. All staff should have training on handling aggressive behavior, including techniques like restraining and seclusion. It requires practice and experience. It's important to undergo training and have the opportunity to practice these techniques before implementing them. Staff injury is always a risk when managing an aggressive client, so ongoing education and safety practices are key at minimizing harm to both patient and yourself. A calm, non-punitive approach is also important when employing techniques to control a client's aggression. The nurse should remain calm, non-judgmental, and non-punitive. Approaching the client with empathy, non-judgment is critical for managing the situation in a way that reduces the chances of escalation. Learning from experienced nurses. Inexperienced nurses can benefit from observing how more seasoned nurses handle hostile or aggressive clients. This observational learning can help develop skills and strategies for managing anger and aggression in a calm, controlled, and professional manner. By maintaining emotional control and practicing safe and effective techniques, nurses can prevent aggression from escalating and provide better care to the clients in crisis. And that is the end of this lecture. Thank you.